Welcome to OET Answers.
Occupational English Test. Listening Test.
Has 3 parts, and in each part, you hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You have time to read the questions before you hear the extracts. You will hear each extract once only. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check answers. Part A. In this part of the test, you hear 2 different extracts. In each extract, a health professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for Extract 1. Extract 1. Questions 1 to 12. You hear a doctor talking to a patient called Mrs. Breegi. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, I have headache. The headache first began 2 months ago. I feel a sensation of pressure. The intensity is moderately severe, making regular activities difficult. I fear I am getting much closer to sinus congestion, or maybe photophobia.
What's your age?
42, doctor.
Do you drink or smoke?
Well, I do not smoke, but I drink regularly.
Tell me if any of your family members have any history of illness.
My father and brother have a history of migraine, doctor.
Is there any congestion in your chest or throat?
Yes, I have some sinus congestion.
Did you have any cardiovascular problems?
No, doctor.
Any gastrointestinal problems in the past or present?
No, doctor.
Are you taking any medications?
No, doctor.
Are you allergic to any medicine?
Yes, codeine.
Do you have any muscle cramps, joint pain, back pain, or limb pain?
No, doctor.
Do you have any musculoskeletal problems, or in the past?
No, doctor.
Well, the sense of smell of your cranial nerves was intact. Neck range of motion was normal in all directions. There was no evidence of cervical muscle spasm. No radicular symptoms were elicited by neck motions. Shoulder range of motion was bilaterally normal. There were no areas of tenderness. Tests of neurovascular compression were negative. There were no carotid brutes. Back range of motion was normal in all directions. Position and vibratory sense was normal. Your gait has no abnormal components. Tandem gait was performed normally. There is no edema or significant varicosities. You have developed migraine without aura. I am going to describe therapeutic trial of Inderal 40 milligrams, half tablet twice a day for 1 week, then 1 tablet twice a day for the next week, and then for the 3rd week, 1 tablet thrice a day. Continue these medications for 3 weeks and meet me again after 3 weeks.
Extract 2. Questions 13 to 24. You hear a vascular surgeon talking to a new patient called Monica Patterson. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Patterson. Your GP has sent you to see me because of some problems with your legs, is that right?
Yes, varicose veins, and they've just been getting worse and worse.
Right. Well, I've got some notes here from your GP, but I wonder if you could tell me in your own words when this started and what's happened so far.
Well, I guess the first time I had problems with my legs was ages ago, when I was pregnant. My son's 25 now, so that shows you how long ago it was. But everyone knows that varicose veins goes with that, don't they? They look horrible at the time, but then they usually disappear again.
And was that the case?
Well, by about a year or 18 months later, they'd gone completely. My legs were looking and feeling fine, and I was back at work then too.
Uh-huh. What do you do?
I was a chef in quite a busy restaurant, so there wasn't much opportunity for sitting around in that job, Doctor, I can tell you. But then, it must be getting on for 4 years ago now, I noticed the veins were coming back. At first I wasn't too concerned, although they seemed to get very scaly, and they itched too around the calves. I tried to follow the advice you find on websites. You know, move around at work, try to keep your feet up on a stool and avoid crossing your legs.
Mm-hmm.
And I did insist on getting a bit of exercise every day. I always managed to fit in walking around town after the lunch service, just for about half an hour or so.
Good. And what treatments have you had so far, Mrs. Patterson?
I first went to see my GP just because they looked ghastly, and I was a bit worried about them. But he said that he could only recommend proper treatment when they got worse and were painful or I had any complications. But he did tell me I should lose some weight. That's an occupational hazard in my job.
Good advice, though.
Well, I did manage to get it down a bit. Anyway, about a year ago, my left leg really swelled up. In fact, they both look pretty nasty with the bulging veins. And you can see now, my feet and ankles are really swollen up.
Yeah.
Also, when I'm in bed, I regularly wake up with terrible cramps. Last night, I didn't know where to put myself. So, then the doctor did an ultrasound scan to see if there was a blood clot. Thankfully, that was all clear. But we agreed it was time to get my legs sorted. Yeah. The doctor arranged for me to have some injections of foam in the veins. He said it was quite a new treatment. It was just with a local anaesthetic, and I didn't have to stay in overnight, which was good. I had to wear bandages afterwards for a week or so, and then those compression stockings for another week.
And since then?
Well, that seemed to do the trick at first. They felt much better to start with, although I had awful headaches for the first few days, which I gather happens sometimes. Anyway, now they really seem to be worse than ever, so I'm back to square one. I'm thinking that either we have another go with the injections, or maybe I need to consider surgery this time. That's obviously more invasive, and I know from other people that I'd be very sore afterwards and would have to take time off work. That's a consideration too. I run my own hotel now, so I can't just close it for weeks on end, can I? So, what do you suggest now, Doctor?
This is the end of Part A. Now, look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete the answers as you listen to the audio. Now, look at the question 25. You hear a discussion between a doctor and nurse about different types of blood tests for leukemia. Now, read the question.
Hello, doctor. What are the different types of blood tests for leukemia?
Well, blood tests, such as complete blood count, can detect leukemia. A complete blood count determines the number of red blood cells, white blood cells, and platelets. Cytogenetics analysis is a blood test in which a sample of blood is examined to check for changes in the chromosomes of the lymphocytes. Peripheral blood smear determines the presence of blast cells and shows the type and quantity of white blood cells. Other various blood tests may be ordered to see how organs are functioning and if they're being affected by leukemia.
Question 26. You hear a discussion about different types of melanoma. Now, read the question.
There are 4 major types of melanoma that have the potential for metastasis, with distinct characteristics. Lentigo maligna is often found on the head and neck region. Superficial spreading melanoma is more commonly found on the trunk, upper arms, and thighs, and is the most common form of melanoma in white races. Acrolatiginous melanoma is more commonly found on the hands, feet, and nail beds, which is similar to lentigo maligna and superficial spreading, in which it has a relatively long, flat phase before it penetrates into the deeper levels of the skin. Nodular melanoma can occur on any skin surface, but is found more commonly on the trunk, upper arms, and thighs.
Question 27. You hear a discussion about lung cancer. Now, read the question.
Hello, doctor. What are the different types of lung cancer?
Squamous cell carcinoma, or epidermic carcinoma, usually starts in the bronchial tubes in the center of the lungs and can cause symptoms early on, especially hematypus. Large cell carcinoma often occurs in the outer regions of the lungs and tends to grow rapidly. Mesothelioma actually begins in the mesothelium, a membrane that surrounds the lungs. Small cell lung cancer usually grows in the central areas of the lungs, and most people have few symptoms until just before they are diagnosed. Lung carcinoid tumors are made up of cells called neuroendocrine cells.
Question 28. You hear a discussion about non-inflamed comedones. Now read the question.
Hello, doctor. Can you please explain to me what are non-inflamed comedones?
With non-inflamed comedones, there will not be redness or swelling of the lesion. However, non-inflamed comedones may turn into a pimple when bacteria invade. Open comedones, or blackheads, is an accumulation of dead skin cells and sebaceous matter within the follicle. Soft closed comedones develop when a plug of cellulose debris and oil becomes trapped within the pore and are covered by a layer of dead skin cells. Hard closed comedone, called milia, have very obvious whiteheads, which is not pus, but rather a mass of dead cells and sebum. Microcomedones occur when the sebaceous duct and pore opening becomes blocked by excess sebum and dead skin cells. Every blemish begins as a microcomedone.
Question 29. You hear a question about acnes. Now read the question.
Hello, doctor. Could you explain to me what are acnes?
Well, there are different types of acne which are not just classified by its severity. Acne vulgaris can appear on the face, back, shoulders, and buttocks. If you break out, most likely it is the acne vulgaris comedomal acne. Appears as bumpiness, blackheads, which can occur anywhere on the face or body that can range from very mild to quite severe. Cystic acne is the most severe form of acne, which can occur anywhere on the face or body. Acne cysts occur deeper in the skin than the typical pimple, take weeks to heal, and can cause a lot of damage to the skin. Because they are so deep, topical acne treatments are not very effective. Instead, oral medications, like Accutane, are the best option. Nodule acne is another severe type of acne vulgaris. Acne rosacea is a type of acne that affects adults above 30 and occurs only on the face. Acne machantia is caused when there is excess heat, pressure, or friction on the skin. This type of acne is most common on the body, but can also occur on the face. Acne cosmetica is caused by products like creams, makeups, and moisturizers, and even certain hair care products cause this type of facial acne. People with excoriated acne chronically and excessively pick at pimples to the point of causing wounds.
Question 30. You hear a discussion about athlete's foot. Now, read the question.
Hello, doctor. What are the different types of athlete's foot?
Athlete's foot is divided into three categories: chronic interdigital athlete's foot, chronic scaly athlete's foot, and acute vestibular athlete's foot. Chronic interdigital athlete's foot is characterized by scaling, maceration, and fissures, most commonly in the webbed spaces between the fourth and fifth toes. With this type of athlete's foot, itching is typically most intense when the socks and shoes are removed. Acute vesicular athlete's foot is the least common type of athlete's foot, caused by trichophyton mentagrophytes, that is characterized by the sudden onset of painful blisters on the sole or top of the foot. This type of athlete's foot is also caused by jungle rot, a historically disabling problem for servicemen fighting in warm, humid conditions. Chronic scaly athlete's foot is caused by trichophyton rubrum. This dermatophyte causes dry, scaly skin on the sole of the foot. The hands may also be infected, although the usual pattern of infection is 2 feet and 1 hand, or 1 foot and 2 hands, and these are most commonly seen in patients with eczema or asthma.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you will hear 2 different extracts. In each extract, you will hear health professionals talking about specific aspects of their work. From 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at the extract 1. Extract 1, questions from 31 to 36. You hear the doctor briefing his juniors about different types of chest pain in female patients. You have 90 seconds to read the questions from 31 to 36. Chest pain is one of the common health issues from the patients in medical OPDS that causes a lot of anxiety in the patient, as it is often connected with a heart attack or angina, and people are well aware of the severe consequences of the symptom. However, a chest pain is not necessarily caused by or originating from the heart diseases. There are numerous other structures in the thoracic cavity. Therefore, a systematic approach is crucial to arrive at the correct diagnosis causing the chest pain. A chest pain in menstruating females has a great significance, as they are less liable to get heart diseases until menopause. Estrogen prevents the development of atherosclerosis. Coronary artery disease or myocardial infarction is very rare in menstruating females. As menopause approaches and estrogen levels decrease, the chances of development of coronary artery disease increases. Reversible loss of blood supply to the heart muscle called angina pectoris or cardiac pain is retrosternal, poorly localized, vague, heavy, squeezy feeling, compressive. Angina pectoris rarely lasts for less than 1 minute or more than 20 minutes. Unless it is a heart attack, patients are relieved in less than 5 minutes on the use of sublingual nitrates or cessation of all activities. Angina pain can also occur in the left arm, left shoulder, the jaws, or neck. Sudden blockage of an artery supplying blood to the heart muscle called myocardial infarction would be similar to this but very severe and lasts longer. The pain will not be relieved by sublingual nitrate or rest, and the symptoms are palpitations, nausea, vomiting, perspiration, blackout, dizziness, or even mortality. Pain that is unlikely to be of cardiac origin is often well localized, lancinating, prickly, sharp type lasting for less than 15 seconds at times. It can also be an aching type but mostly will be aggravated by coughing and deep inspiration. Often, the patient will be able to localize the pain with the tip of the finger. However, the pain that is localized just below the left nipple will never be from cardiac origin. Common causes of chest pain in young females. Mitral prolapse is a common and benign condition. Leaflets of the mitral valve are lengthy, redundant, and bulky. They prolapse into the left atrium during systole. The causes of this pain are unknown. The pain occurs at rest, non-radiating, prolonged in duration, and sharp. Mitral stenosis or rheumatic valve disease is a common rheumatic condition in females and can cause dyspnea and chest pain. The patient will have symptoms like expectoration, a cough, and there would be low-pitched rumbling diastolic murmur that will clinch the diagnosis. A 2D echocardiography will be confirmatory.
Extract 2. Questions 37 to 42. You hear the doctor giving a lecture on the effect of disrupting gut-brain communication. You have 90 seconds to read questions 37 to 42. According to research findings, disrupting gut-brain communication may affect memory and learning abilities. The link between memory and food is a fundamental human experience that we all can relate to. However, the findings have unveiled an intriguing explanation behind this phenomenon, illustrating how strongly the second brain in our gut communicates with our brain. A massive mesh of neurons termed as second brain lies inside our gastrointestinal tract. While this neuronal control system primarily functions independently to manage our digestive system, the study reveals that this neuronal control system communicates with the brain directly through a long nerve called the vagus nerve. The vagus nerve mediates a great deal of metabolic communication between the gut and the brain. For instance, the study revealed how feeding behavior initiated by hippocampus activity is directly activated by vagal nerve stimulation, mediated by signals from the gastrointestinal tract. It appears obvious that signals from the gut would be communicating with the brain in this way, allowing us to know when we should stop eating. But what if these gut to hippocampus communications covered satiety clues or more than simple hunger? Could they also impact cognitive and other memory processes regulated by the hippocampus? A study conducted on this topic that utilized a novel rodent model that terminates about 80% of gut to hippocampus communicators while still retaining fundamental brain to gut motor signaling. The study revealed that when this gut-brain pathway was detached, the rats displayed impaired episodic and spatial working memory. That means the rats could not effectively generate and access spatial memories provoked by the gastrointestinal system. With this disrupted pathway, a fascinating link between our gut and memory is hypothesized. When rats locate and eat a meal, the vagus nerve is activated and this global positioning system is engaged. Therefore, it would be advantageous for an animal to remember their external environment to locate the food again. The artificial electrical stimulation of the vagus nerve can increase memory function. However, this is the first study to find an endogenous connection from the gut through to the hippocampus that mediates this cognitive pathway. Interestingly, this study revealed that the specific vagal nerve disruption studied here did not affect social learning, body weight, or anxiety. The study concluded by raising a concern over the lack of research in this subject. It is recommended that common bariatric surgeries, such as a gastric bypass, have been found to reduce the effectiveness of vagal nerve signaling to the hippocampus. Moreover, a recently approved FDA obesity treatment called V-block therapy has been effective in weight loss by electrically disrupting the vagus nerve. That is the end of Part C. You now have 2 minutes to